Yeah, so thank you for coming. I did my master's thesis in the DRC. I spent the good portion of the last year there. This is kind of a side project for that. I was analyzing a data set of contact tracing data from an active surveillance study on monkeypox in the DRC. And we noticed there was a large proportion of cases that were investigated that were infected with both monkeypox virus and varicella-zoster virus, which causes the disease chickenpox, which I'm sure most people are familiar with. So an introduction to monkeypox. It's a member of the orthopox genus. It's very closely related to smallpox. Very clinically similar, but with a lower case fatality rate and a lower rate of transmission. It's characterized by these lesions on the palms and the soles of the feet. And it's a zoonotic infection, which means it jumps from animal species to humans. It infects a wide range of species. It was first identified in a monkey in a German lab in 1958, which is why it's called monkeypox, but actually its primary host reservoir is thought to be rodents and squirrels and other small forest animals. So it's a bit of a misnomer. But the first human case was confirmed in 1970. And this was during efforts of smallpox eradication, and which smallpox was eradicated globally in 1980, and the vaccine was phased out in the few years following that. The vaccine did give a large protective effect over monkeypox, and so they typically didn't see much monkeypox while smallpox was still circulating. But since it's so clinically similar, they were worried that it would have the capability of filling the ecological niche of smallpox and spreading throughout the global human population. So in the 1980s, WHO implemented the first active surveillance project in the DRC. And at the end of that surveillance period, they concluded annual incidence was pretty low at 0.72 per 10,000 population, with a reproductive number of significantly less than 1, which means it doesn't have epidemic potential. And so they kind of forgot about it for a while. Throughout the late 80s and 1990s, you didn't see many cases, only a few here and there. But that wasn't helped by the civil war that ravaged the country and really hindered efforts of surveillance for many diseases, not just this one. But towards the end of that, they did see a case incidence rising. And so in 2002, the Ministry of Health put monkeypox on the list of nationally notifiable diseases, which are supposed to be sent to the district health center and the national health center at the end of every week or month. And in 2003, the global population became a lot more interested in monkeypox because a shipment of prairie dogs from West Africa were sent to the Midwest of the U.S. and subsequently infected over 50 people. Fortunately, the West African clades are much less severe, so nobody died, but it did stimulate a large influx of funding to study this disease. And so that led to another active surveillance study implemented by the group I worked with from UCLA. They worked with the Ministry of Health and did another surveillance study in the same region as the one in the 80s to look at the differences. And what they found was a 20-fold increase in annual incidence 30 years after the eradication of smallpox. And I looked at the reproductive rate of this, or the change in the reproductive rate from between the 1980s and then, and it did increase, but it's still less than 1. So it's not too much of a threat, but it should definitely be watched because it is increasing. In contrast, chickenpox has a much different epidemiological profile. It's a member of the herpes virus family. And what's interesting is that the epidemiology is very different in temperate versus tropical regions. This is mostly due to climactic factors, it's thought. Temperature, humidity, and exposure to UV light can inactivate the virus. And so in tropical regions, you have much lower population immunity. when you're young, so less children getting infected. It also decreases the transmissibility of the virus, so less of their close household contacts are infected than in temperate regions. This means that the age distribution of cases is typically older for chickenpox because they just are still susceptible to it. And also the strains are different in these regions. So that could also genetically contribute to the different epidemiology. Also, when you have a higher population, you have a higher rate of transmission, but that doesn't necessarily mean that transmissibility is higher when you have a higher population, just that you may see more cases simply because they're exposed, a larger number of people are exposed. So looking at the differentiation between these three diseases, this is relevant because monkeypox is often misdiagnosed as chickenpox and vice versa. And if you're not trained on the differences, then that rate increases a lot. I think the key things to note are that monkeypox has a prodromal fever, so fever starts about 1 to 3 days before rash onset, whereas chickenpox, you typically have fever at rash onset. And you don't see the lymph node enlargement that happens in monkeypox. Similarly, the rash in monkeypox kind of comes all at once and lasts for quite a long time, whereas in chickenpox, vesicles will crust over in about 48 hours, but new ones will kind of pop up sporadically too. The case fatality rate of monkeypox is much higher than chickenpox, and transmissibility is lower, as I've already stated. And then smallpox, we don't see it anymore, but really the only differences, the big differences between smallpox and monkeypox were the case fatality rate and the rate of transmission. But that's why initially people were so scared about monkeypox. You know, is this the same disease? Or, but it's a little bit better for us than smallpox. Obviously not very fun to have, but yeah. And so looking at the history of confirmed co-infections of these two diseases, there haven't been many. There was a large outbreak in Katakombe in DRC, which is in the district that we did the active surveillance in. And this was during the period of conflict, and so to do the epidemiological investigation, they had to return 3 times, which meant that only 7 active cases were able to have samples taken and tested. But 6 of these were from the same household. 2 of these cases tested positive by PCR for both viruses, and 5 tested positive by PCR for monkeypox and IgM antibodies for VZV, which means that they most likely had a recent infection of chickenpox. So it's you can assume that these were all co-infected cases. The next report was in Equator province of the DRC, a little bit to the east of Sankuru. And there were 7 small outbreaks in this report. They were able to take samples from 14 cases, and only 1 of these cases tested positive. So there was co-circulation. There could have been more co-infection, but they weren't able to detect it. And then the next one, Sankuru, DRC, which is the one I'm currently talking about, was it's the first time it's been seen in this high of a proportion of cases investigated, the rate of co-infection. It's about 14% of total cases investigated, and it just simply pops out because you haven't seen that rate before. And I just saw an abstract for the ASTMH conference, a poster there, that reported from the CDC in Chuapa district that they've also seen a high proportion of co-infected cases, so it seems to be a similar epidemiological profile. And so why we saw so few cases before versus 14% now? Better surveillance. People are more familiar with this disease, and so they're better able to diagnose cases of monkeypox. There's also much better diagnostics since the 1980s. Back then, we were only able to test for 1 pathogen per sample, but now you can test for multiple, and so that really helps in identifying co-infections. There also is a higher prevalence of monkeypox but we have no idea about chickenpox because I'm going to report actually the first time that we are able to detect the national prevalence of chickenpox. So potential change, but we don't know for sure. A PhD under Andrew Moyne, who was my supervisor in DRC from UCLA, he looked at these co-infections. He looked at the age distribution, selection bias, and differences in symptomology. Age distributions are not significantly different between the different infection stages. And he looked at symptoms and determined that monkeypox is significantly more severe than a co-infection, and a co-infection is more severe than a chickenpox-only infection. So having a co-infection does not increase the severity of your symptoms. So that was moving into his theory on selection, which was that a co-infection would be more severe and present to a health facility or healthcare worker more often, and thus induce a selection bias. But he didn't find this. He actually concluded that these were independent diseases, just happening to be co-circulating. But I just wanted to look at that a little bit more in depth here. So a bit of methodology about the active surveillance program. The UCLA team was working with the Ministry of Health. They implemented training sessions for healthcare workers and village volunteers that were able to identify cases in villages and report back to the health zone, and then the chef de médecin, or the chief doctor of the health zone, would go and do a clinical investigation, collect demographic data and contact tracing data, and the village volunteers or healthcare workers were supposed to monitor that village for about 14 days after for more cases. This map is, or the map on the left is a bit distorted. It's hard to find good shape files for regions here, but you can see a bit of the geography of the region. Here's a better map. You can see it also has cases in the study overlaid, and this was done in a paper in 2011. In the top right corner, I just wanted to show that these were the maps that they were actually following for the surveillance of the cases. They're hand-drawn by the health centers, and yeah, it's just kind of interesting, you know, that these are the ways that they know the region. A little bit more visualization, loading a motorbike into a pirogue to cross a river, a training session with healthcare workers, and in the bottom left, transporting samples on a road that looks a bit rough. Samples on the back of motorbikes, in freezers to keep the cold chain. So realities of working in the field. And so to estimate the national prevalence of chickenpox, I used data from the Demographic and Health Survey, which was released in 2013 in Congo. And interestingly, this DHS was the first one to implement a national sero-survey for vaccine-preventable diseases in Congo. The UCLA team worked with the surveyors to implement this. They collected blood samples on dried blood cards from children under 5 years old, and tested these samples by ELISA for serological IgG antibody response, which means that either they were vaccinated against a disease or they have previously been infected by it. And chickenpox was one of these diseases. So the sampling strategy of the DHS is a bit complex. It's two-stage based on population, which may be a bit inaccurate since the last national census was in 1984 in Congo. But nonetheless, they chose clusters based on population density. And within those clusters, there were 536. They chose households at random. And of those households, about 8.6% were chosen to undergo biological sampling. So to estimate the national prevalence from this data, I used a package for the R statistical program called Prever that was specifically designed for spatial interpolation of DHS data. So with that, it draws rings around each cluster, and you set the number of observations equal to an optimal number. And in more populated places, the rings are going to be smaller, have a smaller radius to include that number of observations, and in more sparsely populated places, they're going to be larger. And then we apply a kernel density estimator to the rings to take prevalence from nearest neighbors and smooth that prevalence over the surface to get kind of variation, local variations in prevalence from data that's actually meant to be looked at by administrative unit, so large chunks at a time. I should say that this, you can't confirm that these local variations are true because they are smoothed so much over in sometimes large areas. So looking at results, this is from the active surveillance study. On the left, you see cases which are red overlaid with roads in yellow and villages which are the black dots. So you can see that cases generally fall along the roads because that's where most of the population is. And in the top right, the size of dots correlates to the number of cases per village. And so you see some villages are more affected than others, but this map only shows monkeypox cases, unfortunately not co-infections, but it does give you kind of a visualization of where most of the cases occur. So I looked at the distribution of co-infections by health zone. A simple chi-squared showed that these variables are not significantly independent, which means there is a lack of independence, but we don't know exactly what. But you can see Cole has a very large proportion of monkeypox only cases, and that's probably because they have a general hospital there that treats a lot of the monkeypox cases in the region. Maybe not so much that all of them are in that health zone. Loja and Ototo have the highest proportions of co-infection, but again, we can't really say why that is. Looking at co-infections by population, this is relevant for chickenpox because when there's a higher population density, you have a higher transmission rate, and you can see actually that the proportion does increase as population increases. Actually, the highest proportion of co-infection is in 800 to 1,000 of the population level, and that's about 18.9% of the cases detected. And then distribution by age. This really just shows you that most of the people being infected are under the age of 15. But again, it's been confirmed, or it's been determined that age most likely doesn't significantly affect the rate of co-infection. From the DHS data, on the left, I've plotted rural clusters versus urban clusters, so you can see the distribution of that. And on the right, these are the number of observations, which are the number of children that participated in biological sampling throughout the country. And there was a total of 536 clusters, but some didn't have GPS coordinates recorded, and so we were only able to map 490, and this could also affect the national prevalence estimates. So we determined a national prevalence of 7.93, and when you add the weighting variable from the DHS, it's about 8.81%. When you didn't weight the data, it ranged from 0 to 63% nationally, but weighted, it drops down to a maximum of 39.42%. And you can see if I set a different number of observations per ring, on the top left corner is the smallest number, 100 observations, and you see a lot of variation in this map. But you can't really trust that estimation though, because the radius is so small. It really just estimates random error in sampling. So moving up to 500 observations per cluster, it's much smoother. You see a lot less variation, and it's a bit too much smoothing. So we determined the optimal number of observations was around 250 in the middle and the left. And we can still see that there are pockets of high density, or there's a lot of immunity to chickenpox. But in some central regions, it's still pretty low. And when we overlay our cases from the active surveillance over the prevalence, we can see that this area has about 5% immunity in children less than 5. So it's a bit low to be seeing 14% of active cases investigated having co-infections. And again, looking at the number of observations per cluster, these rings are laid over each other, and so the darker areas will be more populated simply because they were sampled at a higher rate. And clusters were chosen by population density. So you can see where most of the population lives in the area, in the Sankuru District where our cases were found. There was not much sampling. So it's safe to say, I think, that we still don't have a great idea of the prevalence in this location. Fortunately, it does give us a little better of an idea, though. On the left is another map from the 2011 paper showing where monkeypox correlated with population. So the brown regions are where there's a lot of monkeypox, but there's also a lot of people. Pink, there's not a lot of monkeypox, but a lot of people. And green, it's mostly forest, and there's most likely a lot of monkeypox, but no, people don't usually live there. And so, yeah, that kind of tells us a little bit about that epidemiology. But again, it's difficult to say with the co-infection if that's actually why we're seeing it. So, in summary, sorry, this was a bit of a quick presentation, so this was the first summary or study documenting this rate of co-infections, and it's also the first report of national prevalence of chickenpox, and so I think it's relevant because there needs to be continued observation of this population and continue to ask questions on why we're seeing this rate. Are they related in some way that we don't know of? And questions about vaccine introduction. There is a quite efficacious vaccine against chickenpox, but would the trouble or the difficulty of implementing a new vaccine in such a remote and low resource setting be worth it to prevent cases of another disease, if indeed it does cause another disease or have a relationship with it? There were quite a few limitations of this study. Surveillance may have missed cases, particularly because a lot of cases are isolated primary cases that were exposed to an animal and have not passed on the infection to other humans. So those cases are easily missed. Additionally, weak health systems and few resources, people didn't have really the time to spend going to a village every day to monitor new cases, and so because of that, there are probably quite a few missed cases. Additionally, data was collected on paper, so it was entered by hand, and inconsistencies between when they initially investigated a case and when they returned made it sometimes difficult to line up cases and contacts, but that kind of refers a bit more to contact tracing stuff. But still, it's difficult when there's so many errors in data. I'm sure a lot of you are aware. And in terms of chickenpox prevalence, the study only sampled children under 5, so we don't have a population-wide estimate of prevalence. That's important to keep in mind. And like I said, sparsely populated areas are not very accurate, so you have to take that with a grain of salt. But we were able to actually visualize the estimated national prevalence for the first time. So, and thank you.